to make it work. Just having technical difficulty. Cool. Thank you. So the definition of malignant bowel obstruction is the mechanical or functional obstruction of the intestine that prevents transit of food and fluids in the presence of incurable abdominal malignant disease. So these patients, by definition, have a poor prognosis. The prevalence is 3 to 15% of all cancer patients, but that percentage will be higher in those patients with a gynecological or digestive tract cancer. There are many causes of malignant bowel obstruction. The cancer can be within the bowel, within the small intestine, a tumour within the large intestine, or within the stomach, as was our case study last week. The cause may be from treatment. There may be adhesions and scarring from previous surgery, or stenosis, perhaps from previous radiotherapy. There are many drugs that can slow the bowel transit and cause obstruction. Most importantly, the opioids. And it is the constipation from opioids that very rarely can cause death from bowel obstruction. And a few patients will have causes of bowel obstruction which are not related to their cancer and which certainly need to be ruled out, such as a strangulated hernia. So how do we assess malignant bowel obstruction? Well, some patients may present with very subtle symptoms, and it may not even cross your mind. They may be slightly nauseated, they may be slightly constipated, and they may have been feeling that way for several days or weeks. And their obstruction will be partial for whatever reason. Other patients will present with severe symptoms, with terrible nausea, terrible vomiting, and terrible pain. There may or may not be abdominal distension, and there may be either constipation or diarrhea. Some patients have a very classic colicky pain, with pain coming in waves intermittently, and other people have pain that's constant. When you examine the patient, there may be a number of signs which help with the diagnosis. Their abdomen may be quite distended. When you listen with your stethoscope, the bowel sounds can be either absent or increased. Some of them, although not many, have the classic symptoms of high-pitched bowel sounds, but other patients may just have very, very loud bowel sounds. And you will find in malignant bowel obstruction that if you listen over all areas of the abdomen, that each part of the abdomen will give you a different sound. Some patients will have demonstrable ascites associated with their cancer. Some will be obviously cahexic. Many will be fatigued with malnutrition. Some will be dehydrated because they've been vomiting for so long. And others may be weak and a little confused. The more proximal the obstruction, the more likely it is that the patient will be vomiting. And in proximal small intestine or gastric obstruction, the patient can be vomiting large volumes, up to 2 or 3 litres a day. For some patients, the diagnosis will be a clinical diagnosis and it may not be appropriate or necessary to do any investigations. You may already have enough information about the extent of their disease to guess that they are in malignant bowel obstruction. However, for those patients for which you are not sure, a plain abdominal X-ray can be useful to help determine whether they are constipated or in obstruction. And that's fairly sensitive for bowel obstruction, about 60 to 70%. It is more useful in distal obstruction, where you will see dilated bowel loops, air fluid levels, and a reduction in gas and feces distal to the obstruction. For some patients, and we will unpick this a little further, a CT scan of the abdomen and pelvis can be considered. The CT scan will reveal the level of the obstruction, the extent of disease, and the presence of ascites. So for a few patients with malignant bowel obstruction, and it is a minority, surgery may provide a better outcome than medical management. For those patients for whom surgery is appropriate, their median survival is around 7 months versus a short 6 weeks for those patients who only have an option for medical management. And the surgeons can help us with resection of the area of obstruction or palliative bypass or diversion. However, the indications for surgery are really very limited in this patient group. Ideally, there will be only one site of obstruction. The patient will still have a good performance status, meaning they're up and about and walking. And they have a good prognosis with the possibility of chemotherapy in the future. Most of the patients we care for in palliative medicine present later than this part of their disease journey. So as you can see, the contraindications to surgery are much longer than the indications for surgery. So those patients for whom surgery is not appropriate include the elderly and frail, those with peritoneal carcinomatosis, which will be seen on CT scan, multiple occlusive levels, palpable abdominal masses, refractory ascites that just keeps coming back even when it's drained, those with symptomatic metastatic disease elsewhere apart from the abdomen, those who are generally very unwell, those who have kidney or liver insufficiency, those who have had abdominal or pelvic radiotherapy, and those for whom there are no possible cancer treatments. That group of patients is the majority of our palliative patients who present with malignant bowel obstruction, unfortunately. So we have already talked about the prognosis for malignant bowel obstruction. And I want to mention it again because if we are beginning to treat these patients for their bowel obstruction, we also need to be having important conversations with them and their family about how much time they have left in order for them to prioritise their time. Now, we've just turned on our noisy air conditioner. Is that interfering with, and we've just turned it off. Can you hear, is it too noisy? I've got a noisy fan and a noisy...
Yeah, it is causing some problem.
It's not that much, but it's okay, Delamy.
Maybe if I
just hear you.
Talk a little louder. No, if our faces start to get really pink, or mine especially, you'll know why. So I'm getting hotter and hotter.
Doesn't seem too bad.
at the moment.
Not your face, I mean the noise.
I know, we've turned it off. So for those patients for which we use a medical treatment strategy, 30% of them will fortunately have a resolution of their symptoms. Their bowel will unobstruct within 7 days of starting treatment. And 80% of them will experience much better symptom control. Their nausea, their vomiting and their pain will become much easier for them. However, their median survival is 1 month, with a 6-month life expectancy less than 8%. So we're going to move on to the medical management of malignant bowel obstruction. Medical meaning the use of medications. Did anybody have any questions before we move on to the next section? Is this something that you have heard about before? Did you know that it is possible to manage bowel obstruction with medications only, rather than the surgeon's drip and suck? Before I started palliative medicine, I had no idea that this was possible. As a GP and having gone through hospital medicine, I had never seen medications alone being used for the management of bowel obstruction. So it is something that's really interesting. This medical management of bowel obstruction is not in your Indian primer of palliative medicine. So today's teaching is really to be aware of it, because as we've heard, this is common, and perhaps there will be a patient that you are managing in the future that you will remember this talk and be able to look up the resources. So to start with some principles for the medical management of bowel obstruction, and that it really needs to start in an inpatient unit, but with the aim and the hope of discharging the patient home for their last weeks. Because their gut is not absorbing, because their gut has stopped working, it's important to give medications via the subcutaneous or IV route. Eventually, if the obstruction is more distal in the gut, some medications can be switched to the oral route. But the aim is to get their symptoms under control as quickly as possible, which is why we start with subcutaneous or IV. It is important to consider their cancer pain as a separate issue and to continue their opioids for their background pain. Once more, you may find that they have better pain control simply by switching the route, because if they're in bowel obstruction, they may not have been absorbing their opioids. So for the medical management, we use combination therapy, and we adjust it according to the patient's symptoms and according to their underlying pathology. We use a combination of opioid for pain, haloperidol for nausea and vomiting. We may use a prokinetic. We may use an antispasmodic. We may use an antisecretory. We may use a trial of steroid, and we may use laxatives. One important principle to remember is that if the patient has painful abdominal colic, then we do not use a prokinetic, such as metoclopramide, because it will make the colic pain worse. Just a reminder for these patients that if we're switching them from oral morphine to subcut morphine, we halve the dose for the 24 hours. The morphine can be given subcutaneously, 4 to 6 hourly, and SOS through a short line, or for those organisations that have them, a continuous subcutaneous infusion through a syringe pump. Theoretically, fentanyl patches have an advantage in terms of an opioid, as fentanyl has less effect on gastric motility, but in practice, it is not used that often. So we'll just break down the individual components of our recipe. So we've got the opioid on board, and then we want to start an antiemetic. And we use haloperidol because, as we learned last week, it's going to hit a good many receptors and will help the patient to feel less miserable. If the patient has no colicky pain, then we can add to haloperidol some metoclopramide. If you're worried and you're not sure if it's going to cause colicky pain, it is okay to give them a one-off trial of metoclopramide, 10 milligrams, either IV or subcut, and see what happens. But in partial bowel obstruction, metoclopramide has the potential to really reverse that bowel obstruction and get their gut going. So it can be a very useful tool. If a patient is having colicky pain, then we want to introduce an antispasmodic. And we would use hyoscine, which is buscopan, and that too can be given IV or subcutaneously. Alternatively, glycopyrrolate can be used, so either or. It's just whatever you are most comfortable using or most experienced using. We can then use injectable ranitidine, 200 milligrams over 24 hours, can help reduce abdominal secretions. By reducing the amount of fluid that is pouring into the gut, just from normal physiology, we can help reduce distension of the small intestine and help reverse the bowel obstruction. Octreotide is an alternative to ranitidine, but studies show that it is no better and it is certainly more expensive. But you will find different palliative medicine organisations over the world simply will have different experience with using ranitidine and octreotide. And if you do any reading around this, you will find that there is some variation between using ranitidine and octreotide. But our unit uses ranitidine because it's effective and it's cheap and it's available. So a corticosteroid is often used for these patients. The reason we use a corticosteroid is because of the anti-inflammatory effect. And I guess we are just imagining that there's a piece of tumour that's edematous and inflamed, causing a blockage. And that if we give a steroid to reduce that swelling, then we might be able to open up the plumbing. So it doesn't sound very scientific, and I'm not sure that it really is, but we give it a go anyway. Corticosteroid does have some antiemetic action, which can help the patient. We're not really sure how corticosteroid works as an antiemetic. It doesn't work as an antiemetic by itself, but in combination with antiemetic, sometimes it helps them to work a little better. I have seen many times in these patients that when we start a corticosteroid, that it increases their appetite, which can be a bit cruel because they are really hungry and they just are imagining all the time what they'd love to eat and they just can't. So we use dexamethasone, 8 to 16 milligrams, either IV or subcut for a minimum of 3 days to get the full effect. But if we feel like things are improving, we can continue it up to 7 days before reducing and stopping. For some patients, constipation may be a contributing factor to their bowel obstruction. It would be important for those patients to do a rectal examination, and if the rectum is full of feces, then suppositories or an enema may help. It is imperative to stop any stimulant laxatives, and also those that are bulk forming and osmotic, because this will make their bowel obstruction worse and the stimulant will cause colicky pain. It is okay to use a fecal softener if the obstruction is distal. Obviously, if they're going to have a Dopacit tablet, then it needs to get all the way to their large bowel, and if the hold-up is proximal to that, there's really no point giving a fecal softener. And in those patients, it's better to use a rectal route. So alongside the medical management, the use of the medication recipe that we put together for the patient, there are non-pharmacological measures we can use. You may be interested to know that nasogastric tubes are very rarely needed in these patients. But for those that have a more proximal obstruction, either the stomach or the proximal small intestine, then a nasogastric tube can give them an enormous relief from their nausea and vomiting. For those with their first episode of bowel obstruction, a nasogastric tube can sometimes help. Their first episode of partial bowel obstruction, a nasogastric tube can sometimes help with resolution. But really, if the bowel obstruction hasn't resolved within a week, then there's no further indication for the nasogastric to stay in unless they have a proximal obstruction. As we know, nasogastric tubes can be very uncomfortable and for some patients intolerable. And there are significant complications, including esophagitis, gastroesophageal reflux, nasal erosion, and bronchoaspiration. We allow these patients to drink free fluids. It makes them feel normal, it gives them quality of life, and most patients don't mind 1 or 2 vomits a day, and that's the trade-off for them for being allowed to drink what they feel like. Those patients with partial bowel obstruction, or who you may be able to partially overcome their bowel obstruction medically, can go onto a fluid only and then slowly introduce a low residue diet that's low fibre. And they can sometimes get a couple of weeks of time where they can eat and drink a little more variety. I've certainly had patients who have enjoyed planning and eating their favourite food, but swallowing the juices and spitting out the solids, and that's meant a lot to them. Very important to keep their mouth healthy and moist, and check regularly for oral thrush, especially because many of these patients are being treated with dexamethasone. A few of these patients will say that they're thirsty, in which case extra fluids can be given subcutaneously at home or in hospital or IV in hospital. But surprisingly, it's not usually necessary because they're allowed free fluids. TPN is rarely appropriate for these patients because of their very short prognosis. This is my final slide, and just to let you know, there are some palliative interventions which can help these patients. A venting gastrostomy, a tube from the stomach to the outside, which is basically like a reverse peg for proximal bowel obstruction, can help drain the gastric contents and relieve their nausea. I have had patients who have had a peg in for other reasons, and they develop bowel obstruction, and we just leave their peg on free drainage. And for those patients, they don't even need antiemetics. So they drink what they feel like. Most of the contents drain out the peg bag, and they have no nausea. And the way that they eventually die is over a matter of weeks. They become weaker and sleepier, but they're able to walk and be at home, and they're not miserable with nausea and vomiting. For those that have a duodenal obstruction, it is possible to have a metallic stent inserted, and for those that have a rectal or a colonic obstruction, it is possible to have a stent inserted as well. If you can find a willing interventional gastroenterologist or surgeon, then it is worth looking at those options. But once more, we're really only talking about gaining weeks for these patients. That is my final slide. So do you have any questions or comments about the way we manage these patients? Vishnu, can you help us?
Hello. Hello. Am I
Hi.
audible, ma'am?
Yes.
Hi. Hi. Being a surgeon, I want to emphasize one point here, ma'am. Hello. Am I audible?
Yes.
Yes. I want to say one more thing.
Yeah.
Before prescribing medicine, we have to know the cause of obstruction, whether it is luminal cause of obstruction or extraluminal cause of obstruction. Whatever the medicine you have said, it will definitely work in extraluminal cause of obstruction. But the effect effect of those medicines in intraluminal obstruction, I think it won't work. I think surgery may be the first option rather than going for medicine.
So once more, it comes down to how many sites of obstruction there is, whether they have a lot of cancer throughout their abdomen, or if it's one site, I agree. Also, intraluminal tumour can cause partial bowel obstruction, in which case the dexamethasone may help. But we would always want the help of the surgeons.
In those cases, you can put stents and all, but in complete obstruction, and the level of obstruction is very important before deciding the medications.
Yeah. So what you're saying is, please get the CT scan and ask a surgeon for their opinion.
Yes, yes. First, you know the cause of obstruction. That is very, very important. After that, we can decide about the treatment, whether one can go for palliative medicine or even though it is a cause for malignant bowel obstruction, malignancy is the cause of cancer is the cause for malignant bowel obstruction. So always, being a surgical oncology resident, I am going for resection. Palliative resection is best. I am going for that.
Okay.
That gives best palliation, long-term outcome.
Okay. So can I ask one question?
Tell me, ma'am.
Yeah.
Ask me.
I'm not Nishu. If a patient is not willing for a surgical intervention, means he.
Then definitely I will go for medical palliation.
If a patient is having an advanced malignancy, knows everything about the disease, and he just.
I'm not audible, ma'am. I'm not clearly. I'm hearing.
If a patient who is having an advanced malignancy knows everything
Yes.
about the disease and is not willing for any surgical intervention,
Definitely. Then we have to go for this, all these medications.
then the
Definitely.
only option left is medication.
Then two more things in contraindications for resection she has mentioned, ma'am has mentioned, that elderly age group and palpable lump and all not included nowadays. We can go for surgery with those conditions. Elderly, first point you stress, no? For elderly, and other one point you told palpable mass. In those cases, you can go for surgery. That too, at least we can bypass the level of obstruction.
If there is one level of obstruction.
If partial, if the patient is having gastric outlet, yes, yes, single level, one level, definitely. If the patient is having gastric outlet obstruction, we can go for gastrojejunostomy. If the patient is having ascending colon obstruction, we can go for iliotransverse anastomosis, transverse colonic anastomosis. So if a single level, even the patient is elderly, even the patient is having palpable mass, we can go for bypass procedures. That will give best palliation. Definitely. I think so. This is my comment. Anybody can take it.
Yeah, no, thank you for making the comment, making it so very clear to us that for a single point of obstruction, it's very important for us to get a surgical opinion.
Yes, yes, definitely. One more thing, ma'am. I want to know the infusion route, no, subcutaneous route of infusion. I think I may not be popular in that. Can you please explain, ma'am? Subcutaneous route of infusion.
Actually, what we practice here is uh, most of the time what we do is subcutaneous infusions only, because when we get these patients in our setup, most of them will have undergone chemotherapy, and they will be reluctant to have an IV. So they will not be very keen in taking multiple pokes. So what I feel is a single poke they can tolerate, and the subcute infusion they can walk around with the subcute infusions with the
Rate of infusion, ma'am?
right
Rate of fluid infusion.
rate of infusion. If we have most of the time, if you start metoclopramide, it is around like maximum we give 60 milligram over 24 hours. We set the syringe driver like that. So
Okay.
yeah, they can walk around with this. Actually, instead of an IV, they can walk around. Yes, sir.
Okay. Thank you. Thank you.
Yeah, I'm Dr. Barani here. With regards to subcutaneous infection, I actually last time also we had a similar discussion. For fragile patients, okay. Nowadays, when we have quite a good access to central lines, central line access will be a much better option than to have a subcutaneous infection infusion,
Anesthetists
which is
will
going to
answer.
create a swelling. The patient will be a little apprehensive. Already they are fragile, and it may not be very easy for us to convince the patient or the attenders or the nearby persons where he is going to have another set of swelling or whatever be it, which okay somehow infuses hydration, increases the hydration level, but maybe the central vein could be.
Okay. The thing is, sir, the subcutaneous infusion we are not giving in a very fast rate. It's like 90 milligram
Yeah.
over 24 hours, and it's very rarely that we have seen a swelling coming
Okay.
for a patient. And even if yeah, for subcute fluids also, we have given like 500 ml in over 24 hours. So
Okay.
it's not like
500 ml in 24 hours. How far it's going to help?
It's not like for a
No, it is
palliative.
not for hydration. Barney sir, excuse me. It is not for hydration. It is for treatment. They are going to give drugs. So 500 ml over 24 hours.
Yeah, it's only fluids, I think.
It's not not for
Nisha.
hydration. I think so. I think so.
So it's for both. So we give medications via a syringe pump, which delivers medications in a
Yes.
very simple.
Medications only. IV fluids.
But we can also, and last week we talked about, and I sent out information about delivering subcutaneous fluids for hydration for patients who are in bowel obstruction.
One more point I would like to say, sir. I think putting a central line is much more riskier than putting a subcutaneous infusion, because I, being an anesthetist, I know it. So
Yeah.
Yeah, you are the best judge in this regard.
so I think subcute, yeah, we have given fluids, but very rarely do we see a swelling coming. We don't give so fast.
Okay, correct. For a central line, you need to have a technician or a technical person should be. We cannot
Yes.
have staff nurses to do that. True. True.
The advantage of subcutaneous fluids is that they certainly can be given at home. Families can be trained to give, their loved one a drink overnight while they're sleeping. They can have a top up if they're feeling thirsty, and they don't need to be able to access a vein at all.
Okay, nice. It has few advantages. Good one. Thank you.
Actually, the subcutaneous fluids can be given, maybe normal saline, it can be given at a rate of 100 ml per hour. So that if you want to finish it by 5 hours, it is okay, you can finish. But usually what is said is give it over 8 hours. So if you want to infuse even 1500 ml, you can infuse it over a day through subcutaneous route. Actually, this subcutaneous route was very popular till the Second World War, and because there were it was not they were not taking care of the subcu site very clean, so that they produce some infection. That's why now it has lost popularity, but now it is coming back. And some of the anesthetist who was working with me, he was telling me that after doing palliative care, even in ICU, he has practiced subcutaneous infusion, because some people, when they come, they don't get IV line, so that they will put so that they will give some subcutaneous hydration, so that the veins will be more easily visible, and they can put IV access. So that's another advantage.
Another thing, are you going to use a single site infusion or multiple sites? 2 buttocks areas, chest, abdomen?
No, we usually use only single site infusion. Through one site, you can give many infusions.
Okay.
If you put a 3-way.
Okay, I thought we can infuse in 2-3 areas.
No, it is actually not needed for palliative care purpose. But if you want to give 3000 ml per day, you can put subcutaneous line at 2 sites and can infuse 3 liters of fluid.
Okay. Good. So does it have any role with regards to level of subcutaneous fat, thin patients and obese patients? Does it have any variance?
Actually, it is said that subcutaneous infusions should be given at the site of region where there is more fat. Even in very thin patients, we have given infusion without any problems.
Okay. Thank you.
So it's very common, the use of subcutaneous fluids in the UK, New Zealand, Australia, and especially in aged residential care, where they once more don't have the expertise to get IV access, but with the elderly frail, it's a really practical way of getting extra fluid into them when necessary. And just as a by the way, when my cat went to the vet, they couldn't find an IV line, and she got subcut fluids as well.
Madam, I just wanted to clarify. For example, all drugs have been given the dose for a 24-hour period. So, do we need to give them in an infusion only, or a top-up? The bolus doses can be tried.
I think I don't have experience with the bolus doses, but I can't see any reason why they can't be given as bolus doses spread across 24 hours. I'm just experienced in putting them into the syringe pump.
By that way, we'll be requiring lesser volume for administration, and we can hope to have a peak onset of effect early compared to infusion.
Yeah, actually, the most of the medications like opioids or it is given maybe given as bolus dose, but when we give metoclopramide infusion, we want a sustained blood level, so that that's why syringe driver is used, because that will increase the peristalsis gradually, and that level will be kept on. So instead of producing sudden peak and sometime because of that peak colicky pain, so when we give through a syringe driver, the level will be constant. So that may also not produce severe colicky pain. So that's why syringe driver is used um, for prokinetic infusion.
Thank you, sir. So should we? Is this the same reason for using Ranitidine or Hyoscine or glycopyrrolate infusion, or we can
Uh,
use bolus in there?
Actually, if you don't have a syringe driver, you can give bolus dose. But for those who have having a syringe driver, they can give continuous infusion. That's all.
Moreover, giving multiple drugs through a single subcutaneous port, either we will have to reduce the rate of infusion, that will prolong the duration of infusion, or we need to have multiple ports for multiple drugs.
No, we don't use multiple pots. Even if you give bolus doses, actually, if you want to give metoclopramide 10 milligram every 4 hourly, that means 60 milligram per day. So 10 milligram of metoclopramide is only 2 ml. So 2 ml single dose, it is not going to cause much problem, and it will be easily absorbed. So I don't think bolus dose is not going to cause much problem in terms of absorption.
Just a query.
Okay.
If we have a single port for subcutaneous administration, and initially we give 2 ml of metoclopramide, followed by 2 ml of or 50 milligrams of ranitidine, and it's because we had all multiple drugs for two,
Yeah.
uh, probably that will not be an issue if we small volumes
Uh,
and multiple drugs.
yeah. Actually, there are some drugs which are not compatible. So if the
That's
drugs
what
are
for
not
my.
compatible, yeah, if the drugs are not compatible, then you should not give. But all these drugs, what Delamy described, are compatible for the infusion, so that you can give it at a single site.
And the way that we do it is we actually combine all of those drugs into a single syringe driver that is being delivered over 24 hours. So I can confirm with Sunil that the drugs are definitely compatible.
Yeah, yeah. Those are compatible drugs.
Apart from the
So, sir,
dexamethasone. The dexamethasone is given at a separate site.
And
Then-
just to add on a common sense kind of approach, that you just keep a lookout of the patient's subcutaneous site as well, and any signs of irritation, you use, change the site. Or and the other thing I'd like to add about subcut is that you don't need for infusion for hydration is you don't need any sort of monitoring equipment like an IVAC or something like that. You just allow it to run freely, because you can't overload the patient giving fluid subcut, which makes it very safe for home use. Not just home use, but in situations like where there isn't a great deal of monitoring available. So much easier for nursing staff.
Madam, you have been using these infusions for the patient. Once the patient complains of any discomfort, so on an average, how long it takes for patient to have a subjective relief of the symptom once the infusion has been started? Over 6 hours or 12 hours or something like that?
Well, usually the most distressing symptom, well, two really, pain. And once you have changed your route because you have worked out the patient's in bowel obstruction may not be absorbing, so they would have, relief from their pain within an hour. And then nausea and vomiting, hopefully within 2 hours that they will be feeling quite a lot better, really. In my experience, that's what I've seen.
Thank you. So the common mixture which you routinely use in a single syringe consists of metoclopramide, ranitidine, and haloperidol, or other combination.
Well, you
We
would,
had
in the
the
syringe
initial
driver?
infusion. What is the initial priority for the drugs? Either we are
Pain.
using metoclopramide for prokinetic action, for NTEC to reduce the bowel volume, and glycopyrrolate same for the anti-secretory action. So are we mixing all these drugs in the single infusion?
No, because first of all, you
To
want to
begin
go
with,
of the pain and the nausea and vomiting, but then you need to decide if the patient is in partial bowel obstruction or full bowel obstruction. If they're in full bowel obstruction, you will just be using hyoscine and ranitidine. If they're in partial bowel obstruction, you will not use hyoscine, you will use metoclopramide instead.
thank you.
Shall we move on to the case discussion?
Okay. This is about a 32-year-old man diagnosed to have carcinoma of colon. He underwent a laparotomy and ileosigmoid cytoside anastomosis on December 2017, and it was found to be having, it was an advanced malignancy with left supraclavicular lymph node. But there was, since it was an advanced malignancy, there was no oncological interventions planned for him. He presented to us with a severe abdominal pain, which was constant with a pain score of 6/10. It was a stretching type of pain, occasionally colicky, most of the time colicky, and lasting for half an hour. Post surgery, he had watery stools, but when he presented, he was having constipation of 1 week duration. But he used to pass play test. But according to him, it was an unsatisfactory bowel movement since last 1 month. It was also associated with nausea. On examination, he was conscious, oriented, vitals were all normal. Systemic examination showed that his bowel is distension, which is mainly gaseous, and he has a decreased or sluggish bowel sounds. Per rectal examination showed it is a pedunculated mass inside the rectum, and other systems were found to be normal. Psychosocial history. He is an unmarried man, lives with his mother. His father died 6 years back. He knows about the disease, but he doesn't know about the prognosis. Family included mother and uncle. Uncle is the one who is the decision maker in the family. He doesn't want us to tell him about the prognosis. How will we manage this case?
Hello? Yes. Have they done any colonoscopy? Oh, sorry. Yeah.
She's got the notes. She's looking up the answer to the question.
They have done a sigmoidoscopy that showed a nodular unhealthy mucosa with lumen narrowing at 30 centimeters from the anal verge, and scope could not be negotiated beyond that.
Yeah, in that case, you should be having a synchronous to malignancy both in the proximal colon as well as in the distal colon, which have been missed earlier. Possible. And so they have diverted to an area where there is another obstruction. Any biopsy has been taken from the lesion from sigmoid colon?
Actually, this patient had a left iliac fossa mass, and they did a exploratory laparotomy. And during that time, they found that nothing could be done except this anastomosis. That's what happened for this patient.
Okay. So the thing is, he had a right iliac fossa mass. Iliotransfer anastomosis has been done.
Sorry, left iliac fossa mass.
The previous slide. In this case, we can try out. I don't know why they have done iliosigmoid. They would have given a transverse colostomy, which would have been much better. What was there inside?
Don't know what happened. It was done by from
I
a
understand.
tertiary.
Actually, they have done iliosigmoid at site to anastomosis when the patient is already having obstruction.
I don't know, but
Okay.
anyway, even during that time, he had symptoms of obstruction. So they may have tried to relieve some obstruction. That may be the reason. I don't know because I am not
Yeah,
a surgeon.
maybe. Yeah, stoma could have been a much better option. I don't know why they have anastomosis, ileum with the sigmoid. In that case, they could have given it as an ileostomy. Okay, now in this case, if possible, I will go for ileostomy.
What about the performance status of the patient now, sir?
Patient is no more actually. We
Oh,
lost
it's no
him
more.
1 month. Yeah,
Okay.
we lost him 1 month back.
Okay. Okay, treatment ends. We can go.
So his symptoms are pain,
Pain, constipation,
nausea.
nausea.
In this case, ileostomy would be better option.
Sorry?
In this case, ileostomy would be better option.
Yeah. True.
But now he has metastatic disease.
Midrectal disease. And then
Actually, they met the operated surgeon, and he told that nothing can be done because the patient was bedbound. He was not doing his even he was unable to move from bed. So his general condition was bad. So the surgeon told even during the time of surgery, it was locally spread. So they are not planning to do any surgical interventions.
Okay, sir. Even though that the easier one is doing ostomy rather than doing anastomosis. Technical point of view, doing ileostomy or bringing out the colon is very easier than doing anastomosis in that patient.
yeah, anastomosis is a bad option.
We
If
can't
the patient
comment
is
on that
alive
because
now, okay.
Yeah,
If
that's
the
true.
patient
That's true.
is alive now, if the
No,
patient is alive now, we can go for what about if the performance status is good and if he is fit enough, then we can go for surgery and bring out the bowel. Otherwise, we can try for palliative measures, that medical measures or stenting we can done. If feasible, stenting can be done to bypass that obstruction.
So a sigmoid stent.
no.
Stent.
Jagdish, the problem is they are not able to even pass the scope beyond. We don't know how long the lesion is. We don't know whether the stent will go to the iliosigma junction or to the primary site.
So if we met this patient, would we all like to guess what his prognosis is? Does he have weeks or does he have months?
Yeah, 32-year-old, hopefully a healthy fellow, with a little advanced colonic malignancy with chemotherapy, they would have been at least few months away. The diversion ileostomy could have given him months of life with chemotherapy.
I'll just read out the exploratory laparotomy findings. He had large hard mass involving the sigmoid colon, 77 centimeter, with dense adhesions to the transverse colon, distal ileum, left kidney, left ureter, and pelvic wall. There were lots of peritoneal mets, omental mets, and around 50 ml of blood-stained ascitic fluid.
So these are all the more indications to do ileostomy, exteriorize the bowel. Possibly they would have done transverse colostomy and given chemotherapy.
Okay, he was
try for pharmacological measures. As of we can try for pharmacological measures now, like dexamethasone.
Do we just have one surgeon in the group?
Two. Three.
Two. Three. Do we have a consensus among the surgeons of what you would do?
Actually, we are discussing actually what surgery we could have done for saving this patient actually. But then when we were seeing this patient, actually his general condition was very poor. He had a distended abdomen and he was in severe pain actually. Initially we started him on morphine, but it responded for 2 days only, and then he came and he was in severe pain actually. So we were more in a point of giving symptomatic relief actually. So that's how actually we proceeded. We can discuss more.
Can I interrupt for a quick minute? Just, I think the question of his prognosis would be really good to get people to put their cards on the table before we proceed and just get a feel for what we think as a group, because it's very critical in how you would manage this patient. So I would estimate possibly, 4 to 8 weeks. That's what they're my cards. Whatever we do.
Yeah, a patient with advanced malignant bowel obstruction. From the literature, I see that the longevity is only 4 to 5 weeks.
So the surgeons would have preferred a different surgery to give him extra months. And it's really great to have surgeons as part of this conversation, because all of us as palliative medicine doctors need brave surgeons who are willing to do palliative surgery, because palliative surgery can relieve an enormous amount of suffering and can give people weeks and months of life. So it's fantastic to hear how quickly you've assessed the situation, and obviously how willing you would have been to have looked at all the alternative surgery. But it seems like this patient had an enormous amount of adhesions and peritoneal disease when they went in there. So we have probably come to the conclusion that this man has on average 6 weeks to live, and that his main problem on presentation was his frailty. He had very poor performance status, and his pain. And so, Nishu, do you have slides about how he was managed medically or not? No. She's looking at the notes.
Apart from the surgery, what all do you think, what all could have been done to give him symptomatic relief? Can we discuss on that? Relating to what we learned today.
Can I?
There are some suggestions on the group chat too about what could be done. Sorry to interrupt.
Sorry, I'm Swati here. I just have a thing. I'm not great in surgery, so all the surgeons kindly excuse me. But I was thinking initially his general condition is poor, as what Dr. Nishu said. So if his general condition is poor, initially why don't we give him parenteral fluids to improve his condition? Meanwhile, to relieve constipation, can we give him enema or something initially? Because even to take food, it might be problem. So, and then why can't we start him on hyoscine? I'm not sure how we can manage it, but maybe this is what initially to improve the condition of the patient. And meanwhile, we can even, because the family was not willing to share what his prognosis to him, because he's a 32-year-old guy. So maybe he has some other plans regarding it. So maybe we need to counsel them to tell him so that he can plan for further things, or what are his last wishes. So this is my opinion about what we can do. So please do correct me if I'm wrong.
Yeah, thanks, ma'am. I think this includes most of the interventions that the management that we did for him. Initially, we started him on morphine, which gave him pain relief for 2 days, but then his pain was colicky and very severe. But then even after giving edema, he had good bowel movements. Not good bowel movements, like he was having satisfactory bowel movements. So we were thinking that he is having a partial obstruction. So we started him on morphine as well as metoclopramide infusion. So with that, for almost like 3-4 days, he was having a pain relief of around 4 to 5 pain score. Then after that, he started having severe pain, and his bowel was also getting distended. So after each meal, he was complaining of severe abdominal pain. So then we reached at the point that we had to talk to the caregivers and then decide on giving him higher Buscopan infusion. So finally, we came to a conclusion that we also started him on dexamethasone, but it was not giving him much relief. So we came to a conclusion that the mass might be increasing in size, and therefore it has come into a complete bowel obstruction. We gave him hyoscine, and with hyoscine he was having adequate pain relief actually towards the end, last days. So this is how we managed his symptoms actually.
So actually here a patient who has abdominal pain, constipation and nausea, but he is passing flatus. That means he is having partial intestinal obstruction. So in case of partial intestinal obstruction with colicky pain, we can definitely start him on steroids. So the first thing we did was I think steroid dexamethasone along with morphine, and he was also given enema. So prokinetics was not given because he had severe colicky pain, and haloperidol was given to reduce the nausea and vomiting also. So within 2 days he started passing motion, and it was watery stool, and he was saying now he is passing enough amount of motion. So he was comfortable in that manner, and his abdominal pain was also reduced. But after 5 or 6 days, I think the pain was increased, and then only the hyoscine hyacinth was given, which gave him relief. And I think after 2 days, he died. That's what happened. And he was also receiving ranitidine.
So another example of optimistic prognostication on my part, Sunil.
Yeah.
But also, I find the diagnosis of a partial bowel obstruction quite difficult, I must say. And I always worry that by using prokinetics as a trial that we really significantly aggravate abdominal pain for patients. I think it has to be done with care. And also the whole principle of drip and suck is to rest the bowel. And I think giving anticholinergics like hyoscine and ranitidine for reducing secretions effectively rest the bowel. And potentially, you can then get reduction of swelling around the site of obstruction and potentially reversal. So it's not, we worry about starting anticholinergics as a kind of irreversible sentence that the bowel can't recover. But actually, I think if you can, reduce the peristalsis against the site of obstruction, you can sometimes get reversal even using anticholinergics. Do you have any comments on that, Sunil or Delamy or others? Have you had experience with that?
Hello.
Saurabh.
Am I audible?
Yes.
I recently had two malignant bowel obstruction patients. Now, both of them, when they came to the outpatient, they were completely obstructed, no passage of flatters, no stool. Then I started them on dexamethasone and hyoscine, and one of them could, his bowel obstruction reversed, he could pass flatters, pass stool, but the other one got relieved for a week or so, and then again landed up in bowel obstruction. And then I restarted dexamethasone and hyoscine. He again got relieved. But then, how long can we continue with the dexamethasone and the because as soon as I stopped his dexa, though I continued with hyoscine, the bowel again got obstructed after 4-5 days. The patient had a general sense of well-being while he was on dexamethasone. It was a large mesenteric mass pressing on the sigmoid colon. But as soon as I stopped dexamethasone, he felt weak, fatigued. He said that I'm feeling a lack of energy, and he demanded for the steroid. So I was a little perplexed that what to do now.
Actually, there are some patients who may require continuous dexamethasone for preventing the repeating bowel obstruction. So you can continue with steroids, and you try to reduce the dose of steroid. If you have started with 16, try to reduce it to 12 or 8 and find out the optimal dose with which his bowel obstruction doesn't occur again. And it may be continued for rest of life if there are no other interventions possible.
Okay, so can we reduce and continue it for a while? That
Yeah.
is probably, yeah.
Yes, you can continue.
Okay.
But very much on the lowest possible dose, as Sunil said. You might even only need 0.5 or 1 milligram just to sustain. That's possible.
And I think what you proved that the patient could not get by without dexamethasone, so it was good that you tried that. Having proved that and understanding that the patient has a poor prognosis, then finding, you know, the lowest possible effective dose of dexamethasone to keep the patient on is the right thing to do.
Thank you.
Okay. When there is any anatomical obstruction, there is a structural obstruction, I think surgery will be the best possible way than to have a load with dexamethasone, whatever be the drugs you want to have. When you identify some structural abnormalities, that has to be cleared first. Whatever be the drugs you are going to give is only going to buy time.
Yes, you are right. But we took an opinion. Actually, the patient was referred by a surgical oncologist only, and the patient actually underwent a radical cholecystectomy followed by the chemotherapy, radiotherapy. Initially was diagnosed as a CA gallbladder, but later on this recurrence was a mesenteric recurrence with a huge mass, and which was pressing the sigmoid colon, and surgeon, 3 of the surgical oncologists have separately viewed, and they denied handling because they were suspecting the interperitoneal disease, and so they denied the surgery. So that is why he was put on the pharmacological management. I'm sorry, I forgot to mention earlier.
Yeah, thank you.
I just want to mention one more point here. In advanced malignant bowel obstruction, usually the obstruction is not only mechanical, it is also due to functional obstruction. So even if you do surgery, there may be some, as you told us, a single discrete obstruction that may be doable for surgery. But when there are usually the obstruction is multiple and it is also functional. So surgery, even though surgery may be successful, the patient may not pass motion because they are having functional obstruction due to involvement of the nerve plexus to the intestine. So that's another thing that has to be considered before surgery.
Thank you, sir. So can I ask one more question?
Yes, please.
Okay. So does substituting, if cost is not an issue for the family, does substituting hyoscine with octreotide makes a difference?
Actually, I have a paper with me which says octreotide is not superior to the usual things like hyoscine bromide and ranitidine.
Actually, there was a lot of insistence, like the patient was also consulting the medical oncologist. That is actually a routine phenomenon in India because patients keep going to the oncologist for exploring options. They were advised octreotide, though I was not very comfortable because I am more comfortable with hyoscine. I explained everything, but family wanted octreotide. So I had to start it because the oncologist was also pressing on it. But I did not find any.
Yeah.
I did not find any significant reduction in volume or anything.
Yeah. Previously, there were a lot of enthusiasm on octreotide, but now there are articles which says octreotide is not superior.
So what can be the, till what dose can we escalate hyoscine, sir? Hello?
I've certainly used 120 milligrams in 24 hours.
Yeah, that's the maximum dose that can be increased. But even there are reports who have used 200 milligram.
Yes, I think Twycross mentions going higher, 200, 240. So, but also, I just going back to that clinical situation where the patient or the relatives are pushing for a treatment. Although, as Sunil says, the papers would suggest that octreotide doesn't provide any benefit, I think it probably doesn't hurt to satisfy the request if it's not a cost issue for the family and patient. Because I suppose you can't be sure in the individual that it may not benefit that particular individual. And so, you know, in the interest of the therapeutic relationship, it's probably good to give it a try as you did, I would think. I don't know if others feel that that's unethical.
Okay, thank you.
I don't think it's
just to, yeah. If anyone else is not asking, can I take the discussion ahead?
Go ahead.
Okay. This patient has now developed, his abdomen was getting progressively distended and he was getting anemic. So I had a doubt that he might be getting he's having hemorrhage somewhere. And since ascites was coming up, I got ascitic tapping done and the patient was having hemorrhagic ascites. Now it is collecting again and again. So we have inserted pigtail today. But would the ascites be also helped by hyoscine or octreotide? I have seen a few papers mentioning that, there's a mixed kind of this thing. Will it help increasing the dose of hyoscine or I'm using octreotide actually for reducing ascites?
I'm not aware that either drug will help the ascites to stop accumulating, but Odette and Sunil may have more information.
Sorry, I am also not aware about this.
Does it at all...
sorry, carry on.
Sorry. Does it at all reduce the pace of fluid secretion?
I've got a feeling you can use octreotide for ascites. I'm just trying to look it up quickly because we don't do it very often, and I don't. So I'm not sure, but it does mention it in a couple of very quick Google. But sometimes you can use aldactone or a diuretic, but you have to be very careful with diuretics that you don't deplete fluid volume too much. But trying to figure out if it's hemorrhagic ascites. I'm not. Does octreotide help with hemorrhagic ascites, Sunil? With hemorrhage, doesn't it have an effect on blood, on bleeding? I've got to look it up.
Octreotide has some role in bleeding, but I'm not sure about hemorrhagic ascites as such.
Not significantly, but just yeah. There is a paper, a pilot study of long-acting octreotide for symptomatic malignant ascites, but I don't know what did not seem effective in prolonging the time to next paracentesis, although improvement in symptoms suggests that vascular endothelial growth factor inhibition merits further investigation. So,
not proven.
And anecdotally, it might be worth a try. I don't know.
Okay. Of late, what I have noticed is many of the cancer physicians have started using lanreotide. I really am not sure about it, but I think the big names are the costlier drugs are a little more fancy. So,
exactly, more expensive. Yeah, longer acting, isn't it? Longer lasting, is it?
Yeah, they are using lanreotide, but I have not used it, so I don't know. But they used it for malignant bowel obstruction, and I'm seeing a few prescriptions these days.
Okay.
So having worked fairly recently in oncology, the oncologists have quite a lot of experience and familiarity with using octreotide for their patients that get the terrible diarrhea when they're having chemotherapy. So I think that's probably why they suggested it. And picking up on what Odette said, I guess families especially need to have their best story about the way that their loved ones were cared for and died at the end of life. And if they feel, even from their point of view, that their loved one got the best treatment available from their perspective, then it's a better story for them. You know, if the cost is no barrier for them. And also it gives them some sense of control, I suppose, which families appreciate as well. If they come up with a suggestion and it's not going to do any harm, it's probably fine to try it. Not unethical.
So sorry, I'm not sure if there does seem to be some theoretical argument for using octreotide with ascites. Has an effect on renin-angiotensin aldosterone system, improves efficacy of diuretics in cirrhosis. Anyway, maybe even has a direct tumour anti-secretory effect. So perhaps.
Well, Odette, if you want to email that link to me, I can get it out to everybody, for those who are interested. And Sunil, if you can send me the paper about ranitidine being at least as good as octreotide, that I can send out to people.
Yeah.
Okay. So just 4 minutes to go. It's been a really interesting conversation today. And it's lovely having people from all the different specialties contributing their perspective today. Was there any final question before we close?
I would like to say thanks. I was late, but I think I would have missed a lot if I would have not just jumped in at the last moment also. Thank you so much, everyone. Thank you so much.
I should say thanks because I was not aware of medical management of bowel obstruction initially. It was all about surgical thing, but right now I could really understand much about managing bowel obstruction medically. You know, with some interventions too, because enema or insertion of nasogastric tube is again an intervention kind of a thing for me. So thank you so much, Delamy. Thank you, Odette, for your suggestions, and thank you everybody for your suggestions.
On Thursday, we will learn about breathlessness, and we will hear from Dr. Anne Broderick, who is American, so you will hear a different accent on Thursday. Goodbye, everybody. I'll be in touch with an email.